Welcome to Medicaid Matters, the only live talk show about the business of Medicaid health care. And now, here's the host of Medicaid Matters, Richard Yaden.
Well, thank you, Braley. Hey, you just can't host a show from Nashville, Tennessee without throwing in some country music every once in a while. Believe it or not, other than being the healthcare capital of the U.S., Nashville is occasionally recognized for the country music industry. But you probably already knew that because our listeners are some of the smartest people in the world. Well, welcome to another edition of Medicaid Matters. You have arrived here on Tuesday, October 25th, 2011, and we are the only live talk show about the business of Medicaid health care. I'm your host, Richard Yaden, CEO of Managed Medicaid Services, and thank you again for taking some time from your busy day to join us. I know for more and more of our listeners, Medicaid Matters is becoming a part of Tuesdays, and that you are turning to this show to keep you informed about all the topics dealing with Medicaid health care today. We're here every other Tuesday, except actually for our first show next month. That's just 2 weeks away. It'll be on a different day, and I'll have a little bit more about that later in today's program. Well, today is going to be a very exciting show. I think all of our shows are exciting, but this one is very unique and very different. We've not had a guest representing the Medicaid state organization on our show before. And in a few minutes, we'll be joined by Dr. Gregg A. He is the immediate Past Medicaid Director for the Commonwealth of Virginia. Dr. Pane and I are going to dig into what is on the minds today of state Medicaid directors and what they have on their plates as top priorities. We have had, over our pre-show chat as well as leading up to the show, a number of questions sent to us that we're going to have Dr. Pane address to the extent that that's appropriate for his experience in the state that he was a part of. But if you have a question that you've always wanted to ask a state Medicaid director, then today is your lucky day. Dr. Pane will be joining us in just a few minutes, and we're going to get to those questions. Now, our regular listeners know that what makes this show unique is, and what sets us apart really from any other business venue that you could be a part of, is that we are live and we are very interactive. You can call us to voice your comment. You can call us to ask a question. You can even tweet it to us if you're signed into your Twitter account. Or you can chat with me online, as some folks have been doing here leading up to the show. And you can do that during the show. And in fact, go ahead and call us now so that we can have some additional questions ready for Dr. Pane when it's his time to come on and when he joins us here in just a minute. The number to call is 626-657-6125. That's 626-657-2125. If you can't call in for whatever reason, maybe you're sitting at your desk at work and you can't make that outbound call, you can chat with us. The chat line is up and open. We're ready to hear your questions and comments through there. If you want to chat with us, go to www.blogtalkradio.com/Medicaid Matters, and you'll see the chat box down at the bottom of that page. You'll want to register. When you sign in for that chat, you want to register. Don't worry, we're not going to send you a bunch of spam or extraneous email. What that does, though, will allow you to stay up to date on everything that's going on with the show, to be reminded for upcoming episodes and things like that. Speaking of our chat line, I wanted to remind you that we do host a chat at the beginning of every show. It's open for about an hour prior to the show, and we're keeping it open after the show just in case you missed a part and have some points to make. So make a point of joining us before our next show on that chat line and be a part of Medicaid Matters. If you're logged into your Twitter account, send us your comment. Our Twitter ID is @MedicaidTalk. Also, if you do get to our show page, which is www.medicaidtalk.com, you can also watch our show, a live feed that we have up and available through Ustream TV. And while you're there at medicaidtalk.com, take our poll. Every month we have a poll. This month's question is, how do we better control dual eligible expenses? We'd love to get your input and your answer. And then each month we'll go over the results of that poll so that you can hear what that's all about. Well, today's show is certainly going to unveil some of the priorities in the state Medicaid director's world. As most of you know, this is a person who has enormous responsibility on their shoulders, and frankly, I can't think of anyone who would be more qualified, more interesting to talk to about this topic than Dr. Gregg Payne. Dr. Payne is the immediate Past Medicaid Director for the Commonwealth of Virginia, and Dr. Payne, welcome to Medicaid Matters.
Thank you, Richard. It's great to be with you.
Good, good. Well, we're certainly glad that you could be here, and I think this is going to be a very, very informative show for our listeners that had a lot of buzz leading up to it, I know, so let's get into it. I thought it would be interesting if you could take a minute and briefly tell our listeners a little bit about your background. I know you've worked as a physician in the past, but tell us a little bit about your background and your involvement with Medicaid, both as an executive and as a physician.
Well, I'd be happy to. I actually got my start as a physician, emergency physician, out in California a number of years ago, and dealt with a lot of Medicaid there. So I got my first taste of health plans and Medicaid, Medi-Cal in this case in California, and began to appreciate some of the challenges that were there, many of which still exist today, and we're working through. So that was kind of my start. I went from there to the state of Louisiana and was actually the Medicaid Medical Director with the fiscal agent there, and work with parties across the state implementing the beginnings of managed care, and had a fascinating time managing a big population, the health needs, and focusing on quality. Was previously director of the District of Columbia Department of Health, and part of the health department at that time was Medicaid, so oversaw Medicaid, which is a big part of your budget and probably your number one tool to reducing health disparities and improving outcomes in a population. And then again, most recently here was one of the 3 physician directors of Medicaid programs across the country. He was the director in Virginia, and basically had a broad look at Medicaid from as a practitioner and different administrative roles, and a lot going on today to talk about trying to improve the program.
Well, that's certainly true. There is a lot going on today in Medicaid. You and I were both recently at a conference, and I think probably the one word that described the one word description we could use for what everybody was talking about would probably be chaotic. There's just so much going on right now. And I know that places a great deal of weight on the shoulders of state Medicaid directors. Why don't you give us just an overview of what state Medicaid director priorities are today?
Well, you said it, big challenge. This is the most change in healthcare really since the 60s, Medicare and Medicaid established. We've waited decades for this. We now have it, and I think a lot of directors are dealing with multiple things at the same time, changes in the program, expansion of the program, health reform, and the like. So it's just a very dynamic time in healthcare in general, Medicaid in particular. So I think state Medicaid directors have a big challenge, as do those who work with them, health plans and others. One of the challenges that relates to what directors think about is, besides the change going on, this is a time of recession, tight state budgets, and budget challenges, which has an impact on your staffing and how well you can execute and what administrative new innovations you might be able to do. So it's really multiple priorities, tight timelines for them, a number of challenges with their information systems and implementing health reform. So just a lot going on for directors. I think most of them, what we probably have in common and what we need to deal with are the following things, at least in my mind. One is a focus on how do we deliver care more efficiently with better value and with better coordination, particularly in our complex populations. And I'm talking about the dual eligibles, nursing home, the disabled, those with chronic disease, and the like. That's where most of your cost is, and I think the biggest opportunities to improve coordination, value, and better outcomes. So that's probably high on everybody's list. I think second, certainly implementing health reform. Medicaid programs are very involved with the exchanges, and some of the opportunities under health reform, various grant opportunities, and certainly I think a new and enhanced focus coming out of CMS and in Medicaid on better value-based purchasing, better coordination, better health outcomes, really emphasizing that and putting their money where their mouth is on that. I think it's a big change. So the move toward healthcare value is key. Everybody has to worry about program integrity and trying to do a better job at taking a look at your data and catching fraud, and upfront looking at your data mining. Some of this prepayment and certainly some after the fact, and increasing your referrals to reduce fraud. I think that's important. And last, I think administrative efficiencies in programs, trying to get paperless, help implement electronic health records for providers, and allow electronic submission of claims, and also better eligibility systems so that we're able to do more electronic on the front end and coordinate programs better, because there's a lot of inaccuracy sometimes in eligibility on the front end of Medicaid. So just a lot of huge challenges for directors during these times. Those are some of the things I know I worried about, and my colleagues did as well. I also sat on the board of the National Association of Medicaid Directors, and these are some of the things I would hear different ways across the country.
Sure. Three of the things that you mentioned there are very interrelated: care coordination, the budgeting situation, and healthcare reform. Healthcare reform is probably going to get modified and changed as we go along. I don't know how much is going to get done between now and the next election. I tend to think that a lot of things are going to be put on hold or just creep along until November of 2012 or shortly thereafter. But it seems like, given that there's not really a light at the end of the tunnel with the recession, and that healthcare reform is going to push more people, or projected to push a lot more people into Medicaid, it would seem that care coordination is kind of the issue that everything begins to revolve around as a way of increasing quality and a way of managing costs. From the state perspective, do you see that as a solution, or how do you see that maybe fitting in differently than that?
I agree. Care coordination is probably job one, is very important. And regardless of what happens with health reform, I think you'll see the same principles either way. One is, I think, in a time of recession, your population's expanding. There's a continued push, I think, toward more electronics in healthcare, for eligibility, for electronic records, for being paperless and claims, and managing your data a lot better. So that trend will continue. And we certainly have a number of complex populations that we discussed earlier that are high cost, and we could have a better outcome in. And I think those will continue to get a lot of attention, as will fraud. So some of these commonalities, I think they're enhanced and they're emphasized under health reform, but will be the case either way. That'll be a huge priority for Medicaid directors. But you're right, Richard. I think coordinating care better, something that's grown up over decades, how medicine is organized by practice, by provider, by setting, and patients flowing through the seams, across the seams of these various parts of our health system, is always where we've had the challenges. And I think it's more so today that we need to pay attention to this to get better value and efficiency. Mm-hmm. That's the place to look, I believe, in Medicaid programs. Easier said than done, but I think a lot of progress is being made by health plans and also and other groups to manage the cost and value better within a population, and to coordinate better between worlds, such as mental health or nursing homes, to the acute side. So that's really where I think a lot of the action is and will be.
Yes. Well, we're going to take a break here for a couple of minutes, and then we're going to hear more from Dr. Pane. This is a great time for you to call in and ask questions, to give us your thoughts. We already have some, so when we come back, we're going to hear, as I said, more from Dr. Pane, as well as to get to some of your questions. Don't go away.
Nurses who want to stay on top of their skills know that the Nursing Informatics Learning Center is the place to go. You'll find articles, tutorials, a blog, e-zine, board-approved CE credits, links, assessments, and consultant services, all available to the global nursing community in one place. If you're a nurse or if your organization employs nurses, you need to visit the Nursing Informatics Learning Center. Go to www.medicaid-matters.com and click on Sponsor.
Medicaid Health Plans of America, ensuring access to better health care. Learn more about the innovative work by Medicaid Health Plans at mhpa.org. That's mhpa.org.
Are you a Medicaid industry expert, state executive, or thought leader? Can you share a perspective about the business of Medicaid that's unique, innovative, or even controversial? If so, you could be a future guest on Medicaid Matters. We are currently scheduling guests, and it's time to share your big idea about Medicaid. Go to our website and send us a message. Tell us what you want to talk about and how we can contact you. Make your voice heard. Make Medicaid better.
Elevating the quality of care with less cost. Today, that's the job of every Medicaid managed care company, but it can't be business as usual. Companies have to coordinate care a different way. The solution is managed Medicaid services. Through our virtual case manager network, our teams of Medicaid assessment specialists, and our new Advanced Care Transitions program, companies can dramatically raise the quality of care without increasing their costs. Visit us today at MedicaidServices.net. Managed Medicaid Services, your best source for innovative care management.
And welcome back to Medicaid Matters. This is the only live talk show about the business of Medicaid health care. We're live here every other Tuesday talking about the business of Medicaid health care. Yeah, I mentioned earlier in the opening of our broadcast that you'll have to hear Medicaid Matters on a different day of the week, and you'll also have a chance to watch the show broadcast live and to meet me at the Managed Medicaid Services booth. We're going to be at the Medicaid Health Plans of America's annual conference in Washington, D.C. on November 6th, 7th, and 8th. Now, this is the annual gathering of Medicaid managed care company leaders, several of which we're going to have on our show during the conference. But don't wait and listen to the conference. Why don't you come by and see me? Why don't you register now to be a part of the Medicaid Health Plans of America annual meeting? We'll be broadcasting from my company's display booth right at the conference. So come by the Managed Medicaid Services booth, watch a live broadcast. I'd really love to get a chance to meet you and to hear your feedback about our show. There's a link on our website to register for the conference, and I hope that you'll do that and I can meet you while you're there. And we're talking today with Dr. Gregg Payne about state Medicaid priorities. The only thing we need now is your input. You can do that in several different ways. Probably the easiest and best way to do it is to call us at 626-657-2125. That's 626-657-2125. You can also tweet us at Medicaid Talk, or you can chat live from the show page on the Blog Talk Radio Network. Just go to www.blogtalkradio.com/Medicaid Matters and send us a question or comment there. Well, Dr. Payne, let's go to one of the first questions that we have that has come in while we've been on the show. This comes from Dr. Jeff K. He's in New York. He says, what are, it says, what are you, but I know this is directed toward state Medicaid directors in general. What are you doing to measure outcomes and reward better practices, especially using acuity adjust episodes of care? In 2 words, what are you doing about realigning incentives?
Well, it's a great question. It's right on the money. I think it's high in everyone's minds, and furthermore, I think this is the way payment policy is going from the federal government. I think the government has never been a bigger payer in healthcare, CMS for certainly for Medicaid as well as Medicare, and they are the ones I think that are promoting things that we've talked about for years, which is accountable care organizations and value-based purchasing, and actually quality driving where your money goes and the outcome going where the money goes. And so they are between grants and policies are encouraging models of better care coordination, focus on outcomes. I think, as the caller suggests, would like to see it move faster, but you're seeing a lot of, I don't want to call them experiments, but there's a lot of innovations and attempts at doing this regionally and locally that will probably bear fruit, and we'll see how this all works out by states reporting on what they're doing. But the bottom line is, as the caller suggests, we are moving in that direction from the old world. And now I think organizations are getting more dollars for doing well, and if you don't do well, you might not get as many dollars. And that translates into the state agency as well as the plan and physicians. They have to find better ways of coordinating care, and it's a challenge. And I think the beneficiary has to be part of the game as well where they can. So I think what the caller is referencing, we're in the infancy of, but we're moving along rapidly. And I think risk adjustment and focusing on quality in complex populations is going to matter as well. And so a lot of challenges to be worked out.
Mm-hmm. Well, off the top of your head, do you know of any states that have addressed this head on and perhaps have established a best practice or something?
Well, I think what happens is regional approaches that work in a given state. Certain states have different philosophies. Some are more conservative, some are more progressive, and you have everything in between, and depending on the fiscal environment in a state. So I think, and you can, CMS has some of these posted, and some of those who grant monies, like the Rob Boyd Johnsons of the world, also have it posted. Mm-hmm. And some states have experimented with the tough populations, with mental health, with the disabled, with better community focus. And I hate to name winners and losers, but I think there's a number of states that have shown progress and innovation on some of these grants and in the approaches they use. You always have to do, I think, what works for you, because it'll be a different solution. I think in Virginia, we tried to work with our advocates and those who care for those with complex populations to work out models that might work for us, but it wouldn't work everywhere. So I think it's in the eye of the beholder, but I think a lot of states are doing a number of fascinating things, and you can look at where CMS awards grant monies is one clue, and what some of these reports to Rob Boyd Johnson and others. We participate in the Max Enroll program, for example, which is a Rob Boyd Johnson program for kids to get better efficiencies in the CHIP program. We made some progress in that regard. So those are, I think, where you find some of the answers.
Great. Well, before we went to the first break, you were talking about multiple priorities that Medicaid directors are juggling right now. Care coordination is one. Implementing health care reform. The quality expectations of Medicaid providers, both payers and providers. Could you maybe give us, let me back up. I know there are multiple approaches that you could take to tackle these problems. What do you think are some of the more promising initiatives that Medicaid directors are launching today to address any of these priorities?
Yeah, and they are interrelated, as you mentioned. These priorities do relate to the ultimate goal here, better value and better outcomes and better efficiency in healthcare. What are they doing? I think most everybody is probably working to expand, managed or coordinated care in some way, and I think in many states that means putting more and more of your populations in the hands of health plans and in managed care entities. I know we were maximizing it. I believe many states are doing that. There's a few of our complex populations are not in managed care, and I think in those areas, which is where a lot of cost is, most states are experimenting what's going to work best for them to manage the disabled, the nursing home residents, the dual eligibles, those with chronic disease, the severely disabled, and the mentally ill. How do you manage that better and coordinate the acute side of the equation as well? That's really where the money is and the opportunities for better outcomes. So I think they're working with their stakeholders, working with grants or innovative approaches to, and working with the managed care companies to how do we deliver that care a lot better. That's what's going on there. I think on the program integrity side, I think most states are aggressively pursuing this where they can, looking at new software, optimizing their surveillance utilization review system in their MMIS system, trying to increase your referrals to the authorities for suspicious cases, and you're recouping dollars. But the flip side of that is you want to do it fairly and reasonably, because you need your provider groups to help you, and they're 99% honest and doing a great job out there, and you need them. So that's a challenge. I know Medicaid directors are looking at that, and then you mentioned the quality. That relates to these other two, but certainly there's a big focus on moving the HEDIS scores, moving the CMS hospital metrics into positive territory so we get better results for what we're putting in. And lastly, I know everybody's rushing to do the electronic record. They're rushing to get more paperless, and they're trying to be basically more user-friendly for docs and hospitals, doing the best job they can. And we got a ways to go, but we're moving in that direction.
Okay. Well, we have a couple callers on the line with some questions, so let's go ahead and get to them before we have to go to our second break. First person I want to bring on is Kelly. Welcome to Medicaid Matters. You have a question or comment?
Hi, yes, I do. Thank you. Hey, Dr. Pane, this is Kelly Yori. I guess I would have a question, or maybe you could perhaps give some advice, specifically around the health reform care coordination with the health home, Section 2703. I look at it as probably the baby ACO of the whole reform package, but how would you best proceed, or what advice would you give me to best proceed with introduction of these care models to Medicaid programs, and keeping up the momentum? Some of the feedback that I've received in the past was that the states don't have the staff or capacity to look into the models, and they're concerned about the cost of implementation. While there is that the federal incentive to care or to provide some of the cost for implementation, there is concern that the outcomes may not be as great as one had thought.
Hey, Kelly, thanks for calling in. You've hit an important area, which is the whole notion of medical homes. It's something that's being encouraged, and there's, to me, medical homes is really just another way of coordinating care and being sure someone's kind of at the helm of the ship, watching out for the patient. And there's different variations of that. I think the big variation would be accountable care organization, where maybe a health plan and hospitals and docs all band together, and you get a huge organization managing information better and really keeping track of the patients and coordinating across those seams and being an overall medical home. On the flip side, you may have very rural areas and a more localized medical home model with certain medical groups, or with a federally qualified health center, something of that like would step up and be the coordinating entity. My own personal feelings are we have had medical homes, the notion for a while. I think we need to do a better job of executing that. That means same-day hours. That means extended hours. That means having availability of why people go to the ER. It's because it's available. They get quality care. They get labs, X-rays, and possibly follow-up. We need to kind of duplicate those principles and work in coordination with our acute settings to really get a medical home where we're on top of people 24 hours a day, and we can also put some incentives with the patient where we can to do the types of things that will keep them healthy. So I think medical home is a continuum, and it's being encouraged by federal health reform, the grants, and the policies of CMS and how they pay for health care. I think it's a good thing. I think a lot of it's execution. So my advice would be to, yes, I think you need to do everything you can to encourage your plans through your contracts and your incentives, the state with the health plan, to emphasize that and do a better job. And then in your fee-for-service program with docs and those who have an interest in rural areas or urban areas, to perhaps come up with innovative models with how you can approach a medical home and incent that behavior. But we've all been doing this for a number of years, and I think it's just accelerated, but it's something we got to keep working at. But I do believe it's a key part of the answer.
All right, Kelly, thanks for your question. You might, and this for all our listeners, you might want to also go through our archives. We did a show a couple months ago with the Chief Medical Officer of Health Plan of Michigan talking about their medical home and some of the issues that they went through in implementing that. Dr. Pane, we also have another question. This comes from Debbie. Debbie, welcome to Medicaid Matters. What's your question?
Thank you, and thank you, Dr. Pane. My question is kind of with what's going on with Medicare, and what we do is, and we're not repackagers, we set up physicians for dispensing. And one of our board members, he was in the public health in Georgia, and he said the biggest problem that patients had was getting their scripts filled. And there was 30 to 40% of them that didn't get them filled, and they ended up in the hospital. Well, for me and a lot of people that I have talked to, and they're learning this, if it's in the physician's office, the physician can make sure they get the script filled. I mean, it's just like going to your pharmacy. And a lot of the studies showed that more and more companies are encouraging physicians to dispense because the studies showed that the entire compliance saved a lot of money. And I was wondering just what your thoughts were on this. Thank you, Dr. Payne.
Well, thank you for a great question. Thanks for calling in today. I had referenced earlier getting the beneficiary is part of the solution here, and I think this relates to that, and you mentioned what maybe providers could do as well. But I think executing, Medicaid population, there are the social determinants of health. Let's not forget about language barriers, transportation, things that poverty can do that prevents you, say, from making an appointment. I know that's one of the biggest problems I heard of from my docs in Virginia was patients don't keep their appointments, and how can we do that? How can we incent that and help them and work around that? Similarly, I think compliance with getting your medicines and filling them. It's a problem for everybody, but perhaps even more in Medicaid populations. But certainly, execution of the basics is something we shouldn't forget about. It's very important. And I think, if you track this in terms of quality and payment, that's a good thing, and try to solve the problems you're hearing. So I think it's in everybody has a piece of making that better. I like the idea of getting care closer to the patient and in the community. I like texting people's cell phones. I like if they need medicine or need an appointment, you can do it right in the community nearby where they work or live. I like that. If there's if it's a pharmacy where they can get some kind of care 24 hours, I like that. Anything we can do to make it easier for people with busy lives and other challenges in their lives to execute what plans are trying to do for them, I think is important. And some part of that's awareness, reminding you of prenatal visit or immunization. Some of it is enabling you to get to a physician or a health entity to get the shot, to get the medicine, and the like. So navigating the health system can be challenging. It can be for anyone, in particular Medicaid patients with complex problems. So I think your question is right on the money in your observation, and I believe as health reform unfolds, states need to factor this into their contracts and their incentives for those providing the care, and everybody needs to own a part of the problem. The state may need to look at their policies, the health plan and providers, the beneficiary, up and down the line to try to make this problem better. So thank you for bringing it up.
Great question, Debbie. Thanks for calling in. We very much appreciate it. We're going to take a pause here down at the bottom of the hour, and then we'll start the second half of our show. The phone lines are still open, 626-657-2125. That's 626-657-2125. Stay with us. There's a lot more to come.
You're listening to Medicaid Matters on the blogtalkradio.com network.
By providing access to the care they need and the quality they deserve, Medicaid health plans enhance health outcomes of our nation's underserved. Listen to this letter to a Medicaid health plan that helped save the life of Juan, a 4-year-old with a rare heart disease.
All of your efforts have created a miracle for my son. Even though he was so close to death, you helped. You made a difference. Now he's coming along, little by little, step by step.
Medicaid Health Plans of America, ensuring access to better health care. Learn more at MHPA.org.
Hey, if you or your company are trying to get a message out to the Medicaid business community, this is the place to be to get that done. Become a sponsor of Medicaid Matters and reach more of the targeted Medicaid community. If you'd like to learn more about being a sponsor, just email us at info@Medicaid Talk or call us at 615-257-1627. Medicaid Matters. You want to make your voice heard.
Hi, this is Clay Ferris bringing you the Mostly Medicaid News headlines for the final 2 weeks of October 2011. Our first headline comes from CBS42.com, Alabama Medicaid creating statewide record system. The state agency recently got a $10.5 million federal grant to build a network of electronic health records. The system is scheduled to launch April 2012. Our next headline comes from the Spokane Journal of Business. state's plan to limit Medicaid patient ER visits draws fire. The Washington State Medical Association reports that many are concerned that the new plan to non-pay, non-emergency visits to the ER may be overlooking key factors related to clinical quality. Our next headline comes from WCTV.tv. Fewer Medicaid ER visits. We've got another story in which Medicaid agencies are trying to non-pay or reduce ER utilization, and others are concerned about the overall impact of quality. Our next headline, ineligible Medicaid recipients cost Virginia millions. Errors have cost the state about $263 million in fiscal year 2009. Our next headline comes from CaliforniaWatch.org. State asking clinics to send back payments for dental care. In an effort to reduce California Medicaid payments, Medi-Cal is asking dental clinics to send back payments for dental and podiatry services amid budget shortfalls in mid-2009. Our final headline comes from the Baltimore Sun. A rehab facility is being charged by Medicare and Medicaid that it has fraudulently overbuilt the programs by $8.1 million, saying what it implemented in its billing system to upcode.
For more information about these news stories, as well as to check out analysis of Medicaid industry topics and job listings, visit us at mostlymedicaid.com.
And thanks again to the people at mostlymedicaid.com for giving us that headline update. Did you know that you can also listen to our show right from the Mostly Medicaid website? You want to cruise over there, you want to explore the site while you listen to great guests, listen to informative content, and when you visit their site, be sure you register for the Mostly Medicaid newsletter and also join their group on LinkedIn. It was listed as one of our top 10 resources for Medicaid information during a show last week. Last month, I guess it was. And if you're not a member of our newsletter list, go ahead and register now. If you're at the MedicaidTalk.com website, you'll get a list of those top 10 resources that you can use and share with your friends and colleagues. Let's get back to our guest and today's topics. Again, you can give us a call and let us know what you think about our subject, 626-657-2125. Tweet us at Medicaid Talk, or you can chat with us from the Blog Talk Radio show page. Dr. Pane, we mentioned this a little bit earlier, and that's the subject of budget. And budget seems to be the biggest challenge that's facing states today. It comes up over and over in almost every conversation I have on this program. What's really, and this may sound like a naive question, but I want you to kind of go beyond the obvious here. What is driving this budget challenge? And then secondly, what are some other solutions that you think could work beyond cutting benefits or reducing membership?
Yeah, I agree. Budget is on everybody's mind, especially these days, and I don't think any state wants to cut benefits or enrollees. You're trying to work smarter, but we're in a recession and tough times, and governors and legislatures, they have to make really tough challenges, and healthcare is just one piece of a number of important challenges they face. So, state budgets are under pressure in that regard, while at the same time you have growing caseloads coming in through social departments across the states due to these recessions. So it's a very challenging time. What it translates into is a growing workload, and then the administrative budget within a state Medicaid agency certainly is going to be the first thing to be held down, and you want to preserve dollars for health care. So states don't necessarily have a ton of leeway for new programs, new innovations, new things a vendor or contractor might bring to you. They don't have a lot of money to do that. And in addition, their employees in the state, we may not have been able to hire. You may have had layoffs. You may not have had raises and bonuses and people doing 2 or 3 jobs each. All puts a lot of pressure on Medicaid programs to execute. So they really have to work a lot smarter here and look for approaches that we're talking about in the show, a better coordinated care and focusing on efficiencies throughout the program, which is a challenge. But I think it's a tough time.
Mm-hmm. No question about it. I'm reading more about the underutilization of healthcare data, that there's, and I think you would agree, there is such a gold mine of information with all the claims data that flows back and forth, with all of the assessments that are done. I mean, just that alone yields a great deal of information. What do you think has to change in MMIS systems to make them more useful?
When we talk about care coordination and better value and cost in the abstract, we're talking about information being the enabler. So this really, Richard, you've identified, this is the enabler. Better and more facile handling of your data, turning it into information and turning it into insight so you can manage a program better. And there's lots of pieces of it. I think it does start with the MMIS, Medicaid Management Information System, which is your heart and soul of your program. And not all of these are the most facile with data. You can't just ask a question and get an answer with multiple variables. They're more older systems, and they don't give you the ability to query efficiently. You can do it with a lot of legwork and effort, but we're short of time to do that. So I think updating your MMIS system and using it is important, as will be getting better clinical records through the electronic health record and through Innovation's health plans might be taking, so we have a better clinical idea about patients. The other area that I think will be important, another two areas, one is with providers, just making it easier for them to call, how you send them letters, the website, paying their claims electronically, and the like will be very important. And the last thing I think is eligibility. I think I heard on your news clips certain states, including ours, having some trouble with eligibility. It can be inaccurate because of the paperwork. Local caseworkers are overwhelmed, and I know we had put a lot of attention into a front-end eligibility portal using federal health reform dollars as part of Medicaid eligibility to find ways to those who are real simple. Can we register them online and avoid a caseworker, a lot of paper, and save that for the tough cases? And second, when you're doing it, can you check eligibility for multiple things you might be eligible for and tie them together a little bit? So using the efficiency of other social needs a person might have, like food stamps and the like, along with Medicaid, might make for a better product, might make for better execution of your health, and a better focus on a state of efficiently utilizing your benefits for your safety net. So those are all, I think, things that we keep working on in the future as we go forward.
You know, you mentioned something interesting about using technology to be more in touch with the Medicaid population. And when I think of the traditional Medicaid population, you're thinking of typically people that are unfortunately in a lower economic situation than maybe the general population is, sometimes very transient in that. Do you think that they would have the access to technology in a way that would be meaningful for some of these technology tools to be used to help?
Yeah, I think it's one way among others to reach people. Certainly, the phone and billboards and stuff in your community close is another way. But you don't underestimate. I think a lot of people, more than you might think, have access to a computer or a cell phone where you can deliver electronic information. A surprisingly large number. We had, through our innovations with the Max Enroll program in CHIP, found that once we offered it, quite a big chunk of new applications, 40% and growing, were electronic online from potential beneficiaries. So I think that is out there, and we need to take advantage of it. I know in our state and others, we had a program called Text for Baby, where you're sending right to a mom's cell phone when you should get a visit, and then maybe after delivery what you should do. But I do think thinking through what you're asking your plans to do and what your policies and how you reward quality and how you pay, consistent with health reform and the Affordable Care Act, is a vehicle to incent and encourage more of this way to reach folks. And you're right, IT, healthcare in the end is a people and information business, and we need to really optimize to take advantage of that.
All right, I need your best 1-minute answer to this question before we go to the next break, and that is, as a state Medicaid director, what information would you have liked to have but couldn't get for some reason?
That's more than a minute answer, but I'll try to be brief. Well, a lot of time when you're running a Medicaid program or a health department like I have, half your day is emergency, so you're making a lot of decisions with limited information. But I think you try to optimize what you have and make good decisions. But at the end of the day, you have to make some tough calls. And I certainly want to know more about my population, what they're thinking, and what's going on in a health plan in terms of strategies they might be thinking about doing, and how I can be a better Medicaid program in encouraging the health plan and the docs, as well as the beneficiary, to do the right thing, and how we can make systems work better for them so we can execute. I think a lot of Medicaid's an execution issue, coordinating care across seams and working closer in the community and knowing more about your population and your providers is the key to that.
Great answer. You did it right on time. I appreciate it. All right, we're going to come up here on our last break. If you haven't been a part of the show, now's the time. The number to call, 626-657-2125. That's 626-657-2125. And we'll be back just after this message.
I hope you're enjoying today's show, and I want to remind you that opinions and viewpoints expressed by guests on the Medicaid Matters talk show are not necessarily those of the host or our sponsors. Thanks for listening, and we'll be back in just a moment.
Every 19 seconds, a child will die because of a lack of clean water. It is estimated that more than 80% of childhood diseases and deaths in underdeveloped countries are a direct result of drinking contaminated water. During the course of this commercial, 3 children will die. You can help make a difference in the lives of these children. By supporting Healing Hands International, you will provide safe, clean drinking water to families and villages around the world. Since 2006, Healing Hands has drilled more than 400 water wells in countries like Haiti, Ethiopia, Zimbabwe, and Honduras. Through the help of people like you, we have been able to bring the gift of clean water to more than 1 million people. To learn more about Healing Hands International and what we are doing to help, visit www.hhi.org. With your help, we can continue this life-saving work and make a significant difference in the lives of children.
Hi, this is Richard Yaden, and I want to take a minute to tell you about Ring Central. For more than 5 years, I've used Ring Central as my primary phone service in all of my businesses. And I know why Ring Central has become the #1 cloud-based phone system. Now, you might say that your company has a phone system, so why would you need Ring Central? Well, does your company ever need to quickly establish a presence in a new market? Do you use remote staff on a temporary basis? Do you have a side business, or do you do project-based consulting? It keeps your mobile phone number confidential and gives you a very professional presence. It's also easy and inexpensive to add a second line at home. And it's all less than $25 a month. If you even think Ring Central could be a solution for you, then you need to check them out. Visit our sponsors page and click on their ad, and you'll get a 30-day free trial. You won't regret your decision.
Business.com is a new partner with Medicaid Matters. Business.com is where business people go to find solutions. Each month they help millions of business decision makers quickly find what they need to manage and grow their business. In turn, they enable advertisers to reach these users through a suite of online advertising products, including business directory advertising. You can find more information on the MedicaidTalk.com sponsor page, and you can make it part of your business and marketing efforts to be more effective. Well, if you've been waiting to be a part of the program, now's the time. 626-657-2125. Tweet your question or comment at Medicaid Talk. You can also chat question in with me here on the Blog Talk Radio show page. And don't forget to vote in this month's poll right on our homepage. We're asking the question, how do we better control dual eligible expenses? And we'll talk about the results at the end of the month. Well, Dr. Pane, why don't we take one of the questions that has come in while we've been here, or actually this question came in advance of the show. And it really touches on something you were talking about just before we went into the break. This question comes from Mike C. in Atlanta. He says the FBI estimates 10% of all healthcare claims are fraudulent. The commercial sector recovery rate is 3% to 5% of F&A claims, and yet no Medicaid program recovers as much as 1%. No U.S. industry incurs this level of fraud and abuse except healthcare, costing taxpayers billions. Why is that, and when will fraud and abuse be adequately addressed?
Well, it's a great question. It's certainly on my list of Medicaid Director priorities, and it's the first question you get in front of a legislative body or a news organization or anybody else, stakeholders, is, are you running a tight ship and an efficient program? That's kind of job one for a Medicaid Director, is keep track of the money, and then obviously get good health outcomes and value. What can I say? I think that I need to say at the outset, the bigger problem, I believe, is waste in healthcare, is inefficient delivery, like we've been talking about coordinating care. I think there is mega millions to be saved there over time as we manage the seams better, as we manage these complex populations better, and that's where our focus needs to be. That said, in some areas of the country in particular, there is a fair amount of healthcare fraud going on. And when you get programs in expansion, like Medicaid and Medicare and Medicaid in particular, rapid expansion, new populations, there is a potential for fraud. And historically, the caller's right, the numbers have not been overwhelming. I think that relates to the technology and the approach. I mean, it's pretty much been a pay and chase. And the focus, we do need to pay our providers quickly, and there are edits in an MMIS system, but they don't catch everything. They're not perfect. So a number of claims do kick out for review, but other ones get paid, and then we look for problems and go after it. I think that's one of the big reasons we want to be good to our providers, and we've taken that approach. The way it's going now, though, driven by the feds and state budgets and everything else, is a much harder look at this, and looking at the various software vendors. There's some great software out there that looks for patterns up front and can identify for states and sort out perhaps where problems are before you pay, and then after the fact as well, target a little bit better to go in and make adjustments, or certainly refer people for prosecution in the small number of cases where that's indicated. Mm-hmm. So I want to assure the caller and everybody that's high on every Medicaid Director's list. It's high on every state's list. You've got to run a tight program. Complex problem, though, because we sometimes don't pay enough, and when you talk about delaying payment, it's always a challenge because you need your network for the expanding population. But it's going to continue to get a lot of attention from Medicaid Directors. I think we're making headway. And it's worthy. I think electronics and IT is going to help us. But you'll see a lot more of this coming up.
Mm-hmm. You read often about, I shouldn't say often, but you do read occasionally about these very high-profile fraud cases where the program has been defrauded by millions and millions of dollars by one entity or one organization. Not saying that's a legitimate organization. It was created for that. And just millions of dollars have been taken out of the system through fraud. Do you think those are anomalies, or do you think there's a lot more of those big mega fraud cases out there that just haven't been uncovered?
Yeah, those certainly get the attention, some of these blockbusters. And while I think they're more the exception, they are big exceptions. And as we all know, sometimes anecdote can trump the data. So you can have a good record, but it just takes one or two of these bloopers, and when you're in a recession and taxpayers or everybody's struggling, it takes just one of those, even in any part of the country, for people to ask, are you running a tight ship here? So it definitely merits our attention. And some of this can be tough to pick off, but I think these advanced systems that are out there, of course, they cost money, and Medicaid directors have to show value in a given year. That's what makes it challenging, but there are systems that are going to, I think, advance the cause here and catch this stuff up front and a lot sooner, and that's on every Medicaid director's list. I've had a number of people in my office, and we did an exhaustive review of vendors and are implementing some of this software up front. It's something states are interested in because it may have a big return on investment, which is always good to hear for states, in a relatively short time frame. The flip side is you hate to get your honest providers caught up in this. I think this is a minority entities, but they can be big numbers. Most providers out there are doing an honest job, doing the best they can, helping the state, helping the beneficiaries, and there are some legitimate errors. But we need to really take a look at training and identifying that group versus the out-and-out fraud. And I think we're on their trail.
Mm-hmm. Let's take another question from one of our listeners. Roland in Detroit asks, in regards to a state's Medicaid program, why does the state not use focus groups of its stakeholders, Medicaid, MCPs, providers, etc., to help them shape a program that would meet the needs of its recipients but also be user-friendly and efficient for all?
Well, I think some do, maybe to different degrees and different mechanisms. I know in Virginia we have a very collaborative relationship with our health plans and stakeholders, and I've heard that all the time, that while they don't always agree with us, they appreciate that we have the interaction and develop things jointly and talk and work together for the common good. Other states, it can be more of an antagonistic or a more difficult relationship, and there's varying degrees. I think the caller's right, and I'm from Michigan originally myself, but I think there's varying degrees of getting input. But I think most states have they have advisory committees, they have a task force, they have projects where they're working with their stakeholders in different ways. I think what he's bringing up is the point that we need to do more of this. We need to hear what our stakeholders think. And I think satisfaction is one of the variables of quality. You're seeing this out of CMS. We want to see people happy with us, and we're taking their ideas and their participants. And I think that's all part of this accountable care movement and focus on quality, and it leads to better solutions. So I think it's something we're all trying to do better, and there is forward progress, some doing it better than others, but I think we do want and value the input. As a director, I would much rather hear it from you in a small meeting than have it blow up on me and see it in the paper. So I think we want to hear this up front, and the bottom line is, per your program, Richard, it's better value and efficiency for the program, for taxpayers, and for the beneficiary, and that's where we want to go.
No question. We just have a few minutes left here, and I wanted to ask you about community-based services. Our company gets involved in doing community-based assessments for Medicaid health plans all over the country. What do you think could be done to increase the use of community-based services in other states?
Yeah, that's a big focus in our state, especially for long-term care out of institutional settings and going to the community, and I think also in mental health and in the disabled. There's still a lot more movement. How do you do it better in the community? I think the challenge has been, and continues to be, having the safety net in the community, everything working together and in place, because if you don't, it's not going to work, and it may actually paradoxically increase costs. There's also the potential for fraud. As care gets further away and less monitored, problems can happen. I've seen this in my own. So you've got to do it carefully, where you're on top of the program, have the right incentives, and have the infrastructure in place to move out of the institutional setting, whether it's a hospital, whether it's a nursing home, whether it's a mental institution. So I think everybody wants to go there. We're making tremendous strides. We're headed in the right direction. But we need to do it with care, and that's really where I think health reform is taking us through the movement to ACOs and care coordination and outcome-based care. I think it's going to drive that to continue. So I know I've made it a priority, and many states are as well.
Well, Dr. Pane, thank you for being on today's show. This has been very interesting and insightful. If someone wanted to get in touch with you, what would be the best way to do that?
90 seconds.
I also want to say, Richard, thank you for having me. And if they didn't like the guest today, I'm sure we enjoyed the music on your show. Tremendous music. And some would dispute though, as Nashville is the healthcare headquarters of the country.
Oh, really? Okay.
Anyway,
that's another show.
Happy to be reached. Thank you again. I'm at AOL.com. Just Gregg Pane at AOL.com. GreggPane at AOL.com.
Great. Well, that's almost all we have for today. Just a few reminders before we get away. You don't want to forget to vote in this month's poll on our homepage, www.medicaidtalk.com. We're asking for your input about dual eligible expenses. Register now for the Medicaid Health Plans of America Conference, November 6th through 8th in Washington. I'll be there and would certainly like the opportunity to meet you personally. And our next show is a different day next month. It's Monday, November 7th at 1:30 p.m. Eastern Time. And that's we're changing it to accommodate the agenda for the meeting. We'll be talking with many of the leaders in Medicaid managed care, so you don't want to miss that show. This is Medicaid Matters. I'm your host, Richard Yaden. Today is Tuesday, October 25th, and I hope to hear from you right here again in 2
10
weeks.
seconds.